So let's talk about Mary's story using the life course. So before Mary's even born, she has two options. She can have the great life that we as all individuals deserve, where our strengths are maximised and our weaknesses are dealt with, or she gets half a life, where the slings and arrows of outrageous fortune undo her. So let's summarise where Mary's life is so far. So before she's even born, we know that Mary had the odds stacked against her. We've got a mum whose education probably wasn't that great and has been cut short. And we know, I think it'd be safe to say that she had fairly poor antenatal care. Mary's then born. She's sort of on the lowest side in terms of her birth weight, and we know mum's not got much extended family support. As Mary moves into toddlerhood, we've got a mum who's really battling with very real concerns around income, food security, poor housing, lack of support. It's not a surprise she's depressed. I would be too. She's also probably not had a depression picked up because of her poor antenatal and postnatal care. We know what depression does to mums. It's very hard for them to stimulate their thriving young children. Mary doesn't get to go to preschool because of cultural issues around the family's beliefs, but also the very real financial barriers. And although mum's done her absolute best with Mary in terms of thinking of getting her school ready, she hasn't had any books read to her or much stimulation at home. And as a result, when Mary rocks up at school, we already know she's going to struggle. We already know that she's 18 months behind her peers. And it's not a surprise she has a language delay. She meets a great paediatrician in Frank, who does get her into speech pathology and OT and a psychologist. But I would argue that this spot here, this gaping chasm, this is a gaping chasm of missed opportunity that we paediatricians come up over and over again. We also get some holistic care in that we get some school support, although it's a little fragmented, and Mary's mum gets support and income. But not surprisingly, we then go on to have continued issues in terms of family dysfunction, and Mary starts to truly fail at school. And really, is that a surprise? Mary has had to, the odds of Mary having this occur are high. She's had to undergo enormous cumulative exposure to negative risk factors. And then by the time I come along, Mary's starting to escape from the difficulties of school and the difficulties of home with drug and alcohol. She's got peers that probably aren't the best for her, and she's really distressed and starting to self-harm. And so then we're left thinking, well, what happens next? And this really matters to you adult physicians out there. This will get worse for Mary in all likelihood. This is a diagram of the impact of adverse childhood events on adult morbidity. And you can see that conditions such as cardiovascular disease, if we could reduce the impact of ACEs on Mary, we'd reduce cardiovascular disease by 25%, or in terms of anxiety, 60%, or even HIV, 60%. So we have to do something. I'll just talk a bit about how do we respond to Mary's story as a paediatrician, and it is a really common story. After a while, for Mary, she starts to feel like her life is a train wreck. Things just aren't going right, and if we're not careful, we start to think the same way. We certainly start to feel like we're the ambulance at the bottom of the cliff and everything's a little bit too little too late. And we've already talked in the Congress about the real dangers of burnout, and I actually think this is something that can truly contribute to this. This is a bit tongue-in-cheek, but also a bit serious. I think there are a number of personas we can take on when ourselves or our colleagues are heading to the burnout phase to make sense of what's going on with Mary if we don't start thinking in the life course model. The first is that of the fatalist. This is Mary's biological destiny. This is all determined before she was born. It's all in her genes. The next is that of Eeyore, the pessimist. There's nothing we can do anyway that works. There's no evidence that we could do anything that makes a difference. When we're in our most self-righteous phase, we can move to the victim blamer. This is Mary's mum's fault for not accessing services. And then when we're at our most bleak at 3 a.m. in the morning, we have an existential crisis. We're all going to die anyway, so why bother? So I'm going to challenge these really quite unhelpful views and put forward a new way that I think we could really make a difference for Mary and also for our own well-being as a college. So let's just deal with the fatalists first. So this is a fantastic slide from Michael Marmot's seminal report, Fairer Society, Healthy Minds, and it's from the 1970s British birth cohort. And we've got basically the sort of ends of a bell curve for IQ at around the age of 2.5. And this is our politically incorrect word, but our smart group, and this is our not so smart group. And the dark green line are those who are high SES, and the light green are those who are low SES. So for those people who are out there who think about this is all biologically determined, what would logically follow is that as children progress to the age of 10, the smart kids should just stay smart all the time and be out on top then, and the not so smart kids should stay down all the time. So let's see what happens. So that's certainly true for the smart high IQ, the smart rich kids, and it's true for the not so smart poor kids. But what's really interesting is what happens to the group in between. And what you can see is that for the smart kids from a lower socioeconomic group, they actually get overtaken by the not so smart rich kids. So I think this is really good for us to remember. The first thing to say is clearly, this bit I think you could argue is biology, there's some regression to the mean, but clearly environment matters. What's going on in this space? High quality preschool, a family who are not having to worry about where the next meal's coming from, probably good quality schools that can support kids. I also think it's good for us all to remember, because Danny Delore brought up a great point in his Indigenous child health session about the model of privilege, and I think it does well for those of us who are in high achieving roles to remember that for the majority of that is because we come from middle class supportive families, not because we were just inherently bright. What about and I've busted that one. What about the pessimists? There's nothing we can do anyway that works. That's quite a favourite for people. There's heaps we can do. I think we have a reasonably good enough evidence base to get on and do some stuff. We know immunisation makes a difference, so these are the interventions that have a good evidence base from conception to about 18 years. We know immunisation, none of us debate that, that makes a difference, but we also know high quality antenatal care, sustained nurse home visiting in the first 2 years of life, breastfeeding support, high quality early childhood education, particularly for disadvantaged kids, supporting parents with parenting, such as a Triple P project, or just very real support, such as how you deal with their food insecurity, and school connectedness, all make a difference. So I don't think we can use the excuse that we don't know what to do. What about the victim blamer? That this is Mary's fault for not accessing services. Well, I think this is where we sort of have to look in and navel gaze a bit and ask, is it? Are we part of the problem? This is data from Canada. There's similar stuff in the US and Australia that shows that 25% of adverse health outcomes are actually due to the way we design our health systems. And this pleasant chap is Tudor Hart, who wrote the very famous inverse care law, which was published in The Lancet in 1971, which states that the availability of good medical or social care tends to vary inversely with the need of the population served. So we need to ask ourselves, is the inverse care law playing a role before Mary was born? This is data from Queensland, South Australia, Northern Territory in 2007, and essentially it shows a relationship between the number of antenatal services attended and the likelihood that you'll have a low birth weight baby divided by Indigenous and non-Indigenous kids. Clearly, the good idea is to have at least 5 antenatal sessions before your child is born. So when Mary's mum doesn't have antenatal services, we have to ask whose fault is this? And sometimes we can say, oh, she's a failure to attend, or she did not attend, and the onus is on Mary's mum to come and see us. I would argue it's our fault, and the onus on us is to make sure our services, although they suit people who are like us, also get out and reach the populations who most need them. Same goes for preschool. Let's just assume that Mary, I could do this for Redfern as well, but Mary lives in a disadvantaged part of southeast Sydney called East Lakes. This is from the Australian Early Development Census. A dark colour means that Mary is highly likely not to have the skills she needs to flourish at school when she starts school. And we now know from Link NAPLAN data that that will mean that she will continue to struggle with school. So we all know that Mary would most benefit from high quality early childhood education. Unfortunately, when we look at attending a preschool program, the dark colour does not mean most likely to attend preschool. It means least likely to attend preschool. So here we have Mary with a triple disadvantage. Firstly, she's poor. Secondly, she's already developmentally at risk. And thirdly, the one intervention that could make a really big difference for her, she can't access. I think that's well beyond Mary's mum's remit. And then if we want to look at actually coming to see us, this is data that Kim Dalziel's currently got in Social Science, Medicine and Press from the longitudinal study of Australia's children. Although we can see here that there doesn't appear to be a lot of difference in Medicare spending for people according to their income levels, although you would argue that for Mary she'd probably be more likely to see a GP. For specialists, there's definitely an inverse care law. Basically, that means that you are less likely to see a specialist the more disadvantaged you are. So, the existentialists, what do we do with that crisis? That's when we remember Hippocrates. Our oath says, "I will remember that I do not treat a fever chart, a cancerous growth, but a sick human being whose illness may affect the person's family and economic stability. My responsibility includes these related problems if I aim to care adequately for the sick." Thus, when we signed up all those years ago, we're actually duty-bound to treat the social determinants of health and inequity as long as we are doctors. So I'm arguing that it's time we started to become an equity-focused physician and that we understand that Mary's experiencing multiple health inequities due to the social determinants of health. These are different to an inequality in that they're not just a difference between things such as being tall and short. An inequity is an inequality that is unfair, unjust, preventable, avoidable, systematic and unnecessary. And it involves a decision about whether we want a just society or not. And currently, I think I've shown you really well that equality isn't enough. Equality assumes that we all start at the same point. We don't. Some of us are more advantaged than others. What we need is proportionate universalism, where we provide services according to need so that we can all stand tall. And unfortunately, this is currently our reality. I'm going to put a plug in for our Inequities in Child Health position statement, which we launched on Monday, just to say that I think we can all be equity physicians. An equity-focused physician designs and provides services based on the best evidence, and proportionate universalism means we regularly evaluate our progress in addressing health inequities in our clinical care. We sensitively seek information from our patients about the social determinants of health the same way we would around any other clinical issue, including housing, food insecurity and income. And we prescribe equity interventions as part of our management plan, such as using Close the Gap on our prescriptions, or getting kids to high quality preschool, or making sure people are getting their benefits, supporting them in their housing and other social capital initiatives. And as Frank says, we also need to advocate for integrated healthcare systems, which is not just my idea or Frank's idea. The Lancet's putting it forward, Aracy has it in its excellent report, and it's actually part of our National Strategic Framework for Child and Youth Health. And time's of the essence. We owe it to Mary to make a difference. So many people would look at Mary right at the moment as a problem. She's not. She's a huge opportunity. This infographic from the Lancet series on adolescence tells us that this generation of adolescents and young adults can transform our future, and we need them at the moment. I think we'd all agree. And we have no more pressing need than to get it right for Mary. And it's not just Mary. We know from epigenetics that we're going to impact on the next 3 generations. So how could Mary's life look if we tried this approach instead? Well, for a start, Mary's mum would have got adequate antenatal care that was accessible for a young woman, a teenager, and as a result, Mary would have been a thriving infant. Mum would also have adequate benefits, so she wasn't struggling with her food security, and her education would have continued. So that meant instead of an isolated, depressed mum, we had a mum who was getting mental health support. We were also getting a mum who had universal access to health services. So it meant that Mary, instead of not being particularly stimulated at home, would have got into a supported play group that was free and would have had a referral to preschool using social services support, which meant that when Mary turned up at school, she would love school and not be 18 months behind and have friends. And although there may have been a bit of a wibble and she needed Frank to just support that speech and OT and school support, it would have been way more effective than it currently is. And when Mary did, as all adolescents do, struggle with being an adolescent and all the transitioning issues and did some risky behaviour, then I would have a good idea of what I do next to be effective. Thank you.